Welcome, everyone, and thank you for joining us today. We're going to go ahead and get started with our webinar, Approaches to Address the Health of Specific Patient Populations in Primary Care. Before we begin, I'd like to go over a few details for today's webinar. To ensure audio quality for all of our attendees, we have muted everyone's lines. That means that you can hear us, but we cannot hear you. Even though your lines are muted, we want to hear your questions. So to ask any questions, please use the chat feature that is on the right-hand side of your screen. You may have to click on the arrow to expand that section, but it is the little speech bubble at the bottom right-hand side. We will answer questions at the end after all of the presentations have concluded. I will now hand it over to Matthew Simpson from AHRQ to open our webinar.
Thanks everyone for attending our webinar here today. My name is Matthew Simpson, and I'm a family physician within the Center for Evidence and Practice Improvement of the Agency for Healthcare Research and Quality, or AHRQ. I provide support to AHRQ's National Center for Excellence in Primary Care Research, which we abbreviate as NCEPCR. Next slide, please. NCEPCR's mission is to support transformative primary care research, tools and methods for implementation, and the next generation of primary care research to improve the delivery of primary care. To achieve this mission, NCEPCR engages in several key activities displayed on this slide. One of the key activities is to communicate important primary care findings to the primary care community. In that regard, I'm excited to announce that we have recently published a series of impact stories that highlight actionable findings from AHRQ-funded primary care research. We'll put a link to those in the chat here. This webinar also represents another way in which we communicate primary care findings to the field and is part of a broader series highlighting the value and impact of primary care research. With this webinar, there are a few things to note. Today's webinar and slides will be made available later on the AHRQ website, and the previous webinars in this series are available now on the AHRQ website. So that website will be in the link in the chat as well. And please, if you missed our previous webinars, feel free to go back and watch some of those. Next slide, please. Today's webinar is focused on approaches to address the health of specific patient populations in primary care. The Healthcare Research and Quality Act of 1999 mandated that AHRQ conduct and support research and evaluation and support demonstration projects with respect to healthcare delivery for priority populations. It is recognized that providing high-quality primary care for different populations necessitates different approaches. This webinar highlights approaches to providing comprehensive, coordinated, continuous, whole-person care focused on specific populations. With that, the objectives of the webinar are as follows. To learn about research to develop community-informed quality measures and implementation strategies for primary care. To learn about research on an evidence-based intervention that can be adapted and implemented to meet the needs of patients, including those with serious mental illness who are insured by Medicaid. And to learn about research to evaluate a measure of shared decision-making for maternity care across demographic groups. Next slide, please. And with that, I'd like to introduce our moderator, Dr. Dominic Mack. Dr. Mack is a professor of family medicine at the Morehouse School of Medicine. He also serves as the director of the National Center for Primary Care, where he focuses on advancing population health through the development of strategies to further research and develop innovations and trainings that advance primary care systems. Dr. Mack will facilitate the Q&A and discussion, which will take place after all the presentations are finished. Welcome, Dominic.
Thank you, Matthew. It is an honor to moderate this outstanding group of primary care scientists. As Matthew said, we will focus on value and impact today. And we will begin with our three presenters providing highlights of their research and implementations of innovative approaches to improve health outcomes for specific populations, and then we'll go into the Q&A. I will briefly introduce our presenters, and I will ask them to tell you a little bit about their roles and responsibilities before they begin their presentations. Next slide. Today we have as our presenters in this order, Dr. Kristina Bridges of University of Kansas Medical Center. Her title is A Patient-Informed Approach to Measuring and Improving Outcomes in Primary Care. Second, we have Dr. Jaqueline Nikpour of Emory University. Her title is A Novel Intervention to Improve Care Transitions for Medicaid Insured Individuals with Co-Occurring Serious Mental Illness. And last but not least, Dr. Rachel Breman of the University of Maryland. Her title is A Measure for Shared Decision-Making in Maternity Care through Communicating Choices, Childbirth Options, Information, and Person-Centered Explanation. And Rachel, hopefully I didn't mess up your last name, so correct me if I'm wrong. So we would start with Dr. Bridges. Will you please get us started? Thank you.
Thank you. Hello, I'm Kristina Bridges. I'm a research assistant professor in the Department of Family Medicine and Community Health at the University of Kansas Medical Center. Thank you so much to AHRQ for inviting me to talk about my AHRQ-funded K01 training award that I just received this August. So this project that I'll be telling you about is in year one, very preliminary, so I'll just be focusing on project design and just a few preliminary results. And since this is a mentored training award, I would like to thank my mentoring team, all from the University of Kansas Medical Center, Drs. Ed Ellerbeck, Diego Mazzotti, Sarah Kessler, and Jason Glenn. All right, next slide. So first, why do we need to improve the way we look at quality metrics in primary care? When we focus only on average patient outcomes, we risk missing critical gaps in healthcare. Specific populations, often those with health-related social needs, experience outcomes that are far worse than the overall average. These gaps remain hidden when we rely solely on broad top-line data. Traditional top-down approaches, even when well-intentioned, can sometimes miss the mark. Experts and regulators may inadvertently overlook the real needs, experiences, and priorities of patients themselves. And without direct patient engagement, our solutions can fall short of making meaningful impact. So that's why community-informed strategies are essential. By sharing our outcome data with community members and listening to patients and community voices, we gain deeper insights into where our health system may be failing and how we can improve. Only then can we begin to close the gaps and create a healthcare system that truly serves everyone. Next slide. So I want to start with this example. This is a version of a quality dashboard that was published in 2022 from a group at UMass Memorial. And here outcomes are stratified by specific patient populations. In this example, it's race and ethnicity. Each row represents one quality metric. So it's showing the percent of eligible participants or patients who completed annual screenings or immunizations. And we can see that there is a spread. There are gaps between different patient groups. This dashboard allowed the researchers and clinicians to pinpoint that they wanted to focus on well child visits as a priority area. They saw the gaps were large. They worked, I think, together with a stakeholder team as well, and they designed targeted interventions, and they actually reduced the gap. So we are replicating this sort of visual dashboard design and expanding to look at differences in our existing quality outcomes by language, zip code, and health-related social needs. We will then share these dashboards with our community stakeholder group, prioritize the gaps that we want to focus on as we are working to improve outcomes for all patients. We'll design interventions and then use our stratified dashboard to measure our progress, which is key. Next slide. So here are our specific research aims. Aim 1 includes the creation of the baseline dashboards, and so that's kind of the step where we are right now. And then we'll use these dashboards to co-develop community-informed measures. We'll share our current quality metrics stratified by patient subgroups and walk through the needs assessment step of intervention mapping with stakeholders. We'll see what is most relevant to the community members, what additional metrics or additional stratification they would like to see. We'll have an iterative process then where we'll gather qualitative data on their perspectives and their feedback on the dashboard, and then we will come back to them with additional data that they have requested until we've generated a list of community-informed metrics of healthcare quality. Then in Aim 2, we incorporate community-informed metrics into our existing quality improvement dashboards in the Department of Family Medicine and Community Health to gather data on barriers and facilitators of institutional use. And at the same time, we will continue through the intervention mapping process with our stakeholder group and arrive at our top priority healthcare gaps. And then AIM3 will take us through the rest of the intervention mapping process, which is really designing these targeted data-driven interventions to close the gaps. And our community-informed quality dashboards then not only allow us to visualize the differences in patient outcomes, but to measure our progress in improving them. So next slide. Here's a closer look at our planned composition of our stakeholder group. So currently we're working with 2 community leaders to help us recruit the stakeholders, and then they will also act as co-facilitators during our sessions that we have planned. One is a community health worker herself. She's from a community-based organization here, and one is a retired pastor, and both have very deep ties to the community. And so in addition to those 2 and our other community members, we have 2 community health workers that are employed by our health system, a quality improvement representative, a few primary care physicians, and 2 representatives from our local health department. Next slide. This is an illustration of the intervention mapping process. And so here are the steps that we're going to move through with the stakeholder group. Step 1 encompasses all of AIM1, where we were starting with our stratified dashboards, and then that we've already sort of created ahead of time, and then working iteratively to answer questions, provide new data and visuals as requested by the stakeholder group, and to do a full problem assessment. Then in AIM2, we continue on to step 2 of the intervention mapping process as we prioritize the healthcare gaps that we want to act on first and create a logic model of the problem. And then steps 3 through 6 of intervention mapping are in our AIM3, where we'll collaboratively design an intervention, implementation plan, and an evaluation plan that utilizes our dashboards as a way to measure our progress. Okay, next slide. So I mentioned that we are in the very early stages of creating these dashboards, but I want to show you what they look like. At first, I want to explain where our data comes from. And how we've gone about the stratification process. So we looked at our adult ambulatory quality dashboard that our quality team has created within our EPIC EMR. We have 3 cancer screenings, 5 measures for patients with diabetes, blood pressure screening, and 5 different immunizations that we check for annually. have eligible patients had these screenings. For each metric, the dashboard includes only those patients who are eligible. And then reports the percentage of eligible patients who have met that recommendation for the year. So we accessed all patient records for each of these metrics and then recalculated the percentage stratified by patient characteristics. So on the right side of the screen, you can see, in addition to race and ethnicity, we looked at language. So we have English and Spanish, our largest language groups, and then we have patients representing other languages, zip code. We are, the University of Kansas Medical Center is right on the state line between Kansas and Missouri. So we have Johnson County is and Wyandotte County are in Kansas, Jackson County is in Missouri. And then between Johnson County and Wyandotte, there's a huge income gap there and also health outcomes gap. So Wyandotte County typically represents the worst health outcomes in the state of Kansas. And so we have 5 zip codes there in Wyandotte County, the 661 zip codes that we look at in particular. And then we're also stratifying by social drivers of health. So whether folks who were screened, which is all of our primary care patients, whether they had 0 needs reported, 1 or 2 or more. And then we can also look by specific need. Okay, so next slide. Okay, here's an example of how our quality measures can be stratified using language. As I mentioned before, we have, the 2 largest groups are the English-speaking population, which is the pink dot here, our Spanish-speaking population, which is the aqua dot, and then all other patient languages grouped together here with the gray dot. And then on the bottom, I know it's really small to see, but we have the scale from 0 to 100%. So those who are further on the left is reporting worse health outcomes. So they're a smaller percentage of these met. And so we have our cancer screenings and some of our diabetes outcomes there, and all of those that we listed before. And what you can notice is, in some metrics, there's a big gap, and others are smaller gaps. So we're just beginning to kind of understand what we're seeing here. Our next step for analysis is to do between group variance to see how groups differ from each other and then also differ from the average that we would typically be measuring, and understand when we wait for patient population size, where we have significant differences. I'll show you just a couple more examples. Next slide. This is a way to look at language where we still have our pink English speaking and the aqua blue is Spanish, but then we've broken down the other languages into regional. And so here, groups of languages are represented by different colors. And you can see, I mean, this is definitely messy and hard to look at, but when we want information about very specific, language populations, this could help us. And our grouping is actually relevant. We have, for example, one community health worker employed who speaks Nepali, Burmese, Karen, and Karenni. So that's like several regional South Asian languages that are spoken by one community health worker. So this kind of gives us a picture. Next slide. This is stratified by social drivers of health, either having reported 0 need, 1 need, or 2 needs. Again, there's groupings in some and more spread out in others. So we're just beginning to kind of look at where we see big differences and if they're clinically relevant. And then the final example that I'll show is specific to one social driver of health. You can go ahead to the next slide. And this is transportation. So if people answered, yes, I have barriers to transportation in terms of getting to doctor's appointments. So yes is represented with a red dot here. And again, I mean, you can see that for some of the immunizations, the gap is really large here. The very bottom one is breast cancer screening, and that's one of the largest gaps there. So maybe we need to talk about specific transportation services to, mammograms and different screening things. So this is going to help us inform those strategies once we start to talk with our stakeholder group. And then my final slide. So this project emphasizes community-informed quality improvement strategies and outcome measures that reflect the lived experiences and needs of patients. It demonstrates how primary care can really lead the way in quality improvement and offer practical real-time tools for improving care. And future users may include primary care clinics, QI professionals, health systems aiming to co-design effective community-informed interventions. Thank you all so much for listening.
Dr. Nikpour, you can go ahead and start.
Okay, well, thank you so much to AHRQ for having me and to the NCEPCR for inviting me to share this work. And thank you, Dr. Mack, for the introduction. So just a quick note, in addition to my role at Emory, I also hold an adjunct role at the University of Pennsylvania in the School of Nursing, and I'm a co-I on the AHRQ-funded R18 that I'll be presenting today. My colleague, Dr. Margot Brooks-Carthon, who is our study PI, couldn't be here today, so I'm kind of filling in on her behalf. Next slide, please. So I'm going to first share a little bit about the problem that this intervention is working to solve, which is that hospitalized Medicaid insured adults often have significantly worse outcomes after discharge than their non-Medicaid insured counterparts. By definition, Medicaid insured folks are low income, and so in addition to their clinical course, these patients often have some unmet health-related social needs. One of those unmet needs is often that patients may face barriers to accessing primary care or specialty care following discharge. This could be because they don't have transportation set up to go to any follow-up appointments. They may not be able to afford co-pays, especially hourly wage workers who may have lost income during hospitalization, or they may not be able to find a provider who accepts their insurance, who accepts Medicaid. Now, these are all solvable problems, and often in the Medicare program, a lot of that care coordination happens through home care, which can kind of help ease the transition between hospital and primary care follow-up. But in the Medicaid program, even though typically Medicaid insured patients in Pennsylvania are eligible for home care, because of some of the administrative complexities and logistics around home care referrals, a lot of times those referrals and those connections don't get made. And in fact, when we first started this program, only about 1 in 5 of our Medicaid insured patients were getting sent to home care. And then, as I mentioned, a lot of these patients have competing economic demands that can be exacerbated by a hospitalization and prevent them from getting their needs met and staying out of the hospital. Next slide, please. So knowing all of this, our team in 2019 developed an intervention called Thrive that specifically sought to address the needs of Medicaid insured or Medicaid eligible but uninsured patients during that time of hospital to home transition and primary care follow-up. So Thrive is a transitional care pathway that, unlike many other transitional care pathways that exist, is not limited to a specific age group or such as older adults or a disease-specific program like those that exist for cancer care or heart failure. We care for patients across all age groups and disease states, so long as they are Medicaid insured and are being cared for in one of our now 3, soon to be 4 hospital sites within the University of Pennsylvania's health system. And so the way that Thrive works is that when a patient is eligible based on their insurance status, there's actually a flag that pops up in the EHR in the hospital so that case managers and clinicians can see, hey, this patient is eligible for this particular home care program and make that referral. Once the referral is placed and the patient is discharged, we aim to have a home care nurse go out and visit them, typically within the first 5 days after discharge, if not sooner. That nurse can assist with everything from chronic disease management, coordinate follow-up care, provide education, etc. But they can also circle back and follow up with the physician or the advanced practice provider who actually discharged the patient from the hospital, and they can clarify any discharge orders or medications and really close that loop. Then after that first initial home care visit gets done by the nurse, we meet weekly as a team with our clinical partners to provide 30 days of post-discharge coverage. And during these meetings, we can see, okay, what's all going on with this patient? Maybe should we send out a social worker? Should we send out a physical therapist or occupational therapist or speech therapist? Whatever it may be that patient needs. Should we send out a community health worker? During our meetings, when we kind of identify some of these needs with our patients, we can schedule a follow-up appointment. We can provide connection and application assistance for any social services or relevant programs, provide transportation to and from appointments, and a lot more. And we often will connect our patients with those community health workers, especially if we identify a need for any sort of social support, which is pretty common. Next slide, please. And so kind of on that note of social support, about 1.5 years into developing Thrive, we kind of inadvertently realized that a whole lot of our patients, in fact, probably about 1/3 of our patients, live with some form of serious mental illness, typically major depressive disorder, schizophrenia, or bipolar disorder. Now, myself and a few other members of our team have a clinical background in psych mental health. I am a psych nurse by background, and so we realized that even though this diagnosis of a serious mental illness or SMI was not the reason these patients were being hospitalized, they have having that kind of a comorbid serious mental illness can lead to a lot of challenges with self-management, can impact a patient's medication regimen, right? Think of different interactions that certain medications may have, can exacerbate other health-related social needs. And all of this is what the literature tells us and can kind of add another layer of risk for a readmission or a post-discharge emergency room visit. And so as we kind of look to expand Thrive and sort of adapt to our patients' needs, we were kind of thinking, okay, how can we take this program that we have and tailor it so that we're really ensuring that Thrive is meeting the needs of all of our patients? Next slide, please. So with all of that in mind, here with this particular grant, our first aim was to adapt, implement, and evaluate Thrive in a new safety net hospital system that cares for a particularly complex population. On the right here, you'll see a picture of the Hospital of the University of Pennsylvania Cedar campus, or HUP Cedar as we call it. So HUP Cedar is a 100-bed safety net hospital deep in West Philadelphia. Over 50% of the patients who are treated here are dually enrolled in Medicare and Medicaid. So that's kind of another group of interest for us. And right now we're about 1 year into the grant. And so this adaptation and implementation has been our primary focus, with sort of evaluation kind of being an ongoing process. So second, we'll be examining differences in utilization outcomes, including readmissions, ED visits, primary care follow-up between all Thrive patients versus those getting usual care, but then specifically amongst our patients who live with a comorbid serious mental illness and see, okay, is this meeting their needs sort of on par with how we're meeting the needs of our other patients who don't live with an SMI? And then lastly, we'll be looking at feasibility and acceptability outcomes for both clinicians and patients, particularly patients with that comorbid SMI. Next slide, please. So as I said, we've been at this project for about a year now and have largely been focused on that adaptation and implementation in a new site. And that's really involved a lot of participatory engagement work and multi-stakeholder collaborations. If anyone here is sort of involved in the implementation science world, you're probably very familiar with this. So in addition to implementing the program itself at HUB-CEDAR, we've kind of established ongoing working groups with hospital and home care staff, patients, caregivers, along with beginning to interview patients once they complete Thrive to kind of understand their experiences, particularly if they have a serious mental illness, and really get an understanding of, is this meeting sort of the full spectrum of all of your healthcare needs? And then as we continue to scale up and bring more patients into the program, we'll be conducting a type 1 hybrid step-wedged RCT. Next slide. So I want to talk a little bit about some of the outcomes we've seen to date in Thrive. This slide that you'll see here is from our flagship hospital in West Philadelphia. And in many ways, this is a hospital that has a very similar patient population to those that we're seeing at HUB-CEDAR at our new site. And in our first couple of years, we found that readmissions and emergency departments for patients who were receiving Thrive were virtually cut in half, right? You have got about a 28% readmission and ED visit rate. And then amongst those who are getting Thrive, that's about 14% for both outcomes. And so given that we're caring for a pretty similar population across hospitals and knowing that providing this really integrated wraparound care really does address a need and move the needle on patient outcomes, we're really hoping to see some similar results at HUB-CEDAR. Next slide, please. Another key finding that we're hoping to replicate is among our serious mental illness subgroup. Again, this is sort of where my focus is as someone who has a background in psych. So here you can kind of see we're comparing Thrive patients who live with SMI to those who live without SMI who also completed Thrive. And we're not really seeing any differences in Thrive patients who do and do not have a mental illness in terms of outcome differences with readmissions, ED visits, nor are we seeing any difference in primary or specialty care follow-up. In fact, the vast majority of our patients in both groups were receiving that follow-up. And despite this kind of lack of statistical significance, we see this as sort of a positive result, because if you look nationally, about just at Medicaid insured individuals, those who live with a serious mental illness are about 30% more likely to be readmitted versus those who do not live with a serious mental illness. So we're actually kind of closing that gap. The one outcome that we did see some differences in was that patients with serious mental illness were more likely to be referred to a community health worker. And again, that really kind of emphasizes the role of social support, navigating some of these challenges and being a liaison between the patient and the health system. Next slide, please. And lastly, this pie chart demonstrates kind of some of the common needs that we see in our patients in Thrive. Most commonly, we see patients who lack social support in the home, who have a need for a home health aide or a caregiver, a real lack of health literacy, transportation issues getting things like durable medical equipment, so diabetic shoes, CPAP machines, and then just the stress and anxiety of being in the hospital and coming home from the hospital and not really kind of knowing how you're going to do once you get home. And you can see how some of these issues, especially around stress, anxiety, social support, might be exacerbated amongst those who live with a comorbid serious mental illness, kind of making it all the more important that we adapt our care kind of processes to serve that population. Next slide, please. So as we're thinking about some of the lessons that we've learned throughout our time with Thrive and kind of moving forward with our new sites, I think it's really important to note that Thrive is a nurse-driven intervention primarily, but it really is made possible by our interdisciplinary group of stakeholders, including social work, physical, occupational therapy, community health workers, and the discharging hospitalists, the physicians and APPs who work with us to provide that kind of closed loop coverage. One question that we get asked a lot is, well, how is it that if you have a hospitalist who's, how do you have hospitalists that are willing to provide an extra 30 days of coverage when they're not getting paid after that patient has been discharged and is off their caseload? And when we ask our providers who we work with that question, across sites, we kind of get the same response, which is, well, I'm on the phone all day. I would rather get a 10-minute phone call from home care nurse or whomever to clarify a simple medication order, discharge order, or whatever, than have that patient not get their needs met and end up being readmitted and back on my caseload for another stay for a week or two. So it really is kind of a win-win situation when you think of the hospitalist, the clinician side, and the patient side. Same thing when it comes to getting case managers to refer eligible patients to Thrive. We found that the time it takes to place that referral and get patients to agree to receiving Thrive services through home care is pretty negligible, and it doesn't really add to everyone's workload. But at a new site like Hope Cedar, it kind of takes time for that practice to become normalized. Again, any of my learning health system colleagues can probably attest to that. And so knowing that the barriers are pretty minimal, thinking about behavior change so that that connection to Thrive becomes seamless. We also now have been implementing Thrive with the University of Pennsylvania's health system in different hospitals for the last 5, almost 6 years. And so kind of going into a new site, a lot of our home care partners who have been with us throughout this journey are really taking the key tenets of Thrive and bringing it into their own practice. So for example, a home care nurse who may have breezed through a social needs questionnaire in the past might be taking more time with that, even if they're not necessarily caring for a Thrive patient. And asking again, do you have enough food at home? What's your living situation like? And that's great because it means more patients are going to be getting the care that they need. But also one thing that we're kind of thinking of is how are we going to be able to continue to detect those meaningful differences as this becomes the norm, which in my opinion is a pretty good problem to have, but it's something that we're thinking about. And then you'll kind of see here a quote from one of our hospitalists who works with our group and sort of the benefit that she gets from it. Next slide, please. So I would like to close just by underscoring the potential value of having a program like Thrive, particularly in primary care. We're all primary care stakeholders. My entire research career is in the primary care setting in some way. And so we know that a really high functioning primary care system includes well-coordinated care across settings, addressing complex health and social needs, and delivering whole person, patient-centered integrated care. And because we've seen really promising findings from Thrive, which really seeks to do exactly that, we've actually been able to work with the health system and are actively working on ways to continue integrating this program and having it become self-sustainable. And I want to close with this quote from a participant who has SMI and who was part of our Thrive community. I will probably never forget this. She said this to me through tears when I asked her about her experiences. And she said, I am not a person that depends on everybody, but with Thrive, I felt seen, I felt valued, I felt heard. And I think that just kind of speaks for itself in terms of the power that programs like this can have. So thank you again for your time and your attention, and I look forward to answering any questions you may have.
Hi, everyone. Thank you so much for joining us today. My name is Rachel Blankstein Breman, and I'm from the University of Maryland School of Nursing. It's nice to have two nurses on this panel. I am a nurse researcher primarily, but I mentor and teach primarily doctoral students, and that's most of what I do. So we can go to the next slide. So just to sort of set the stage, my work is very much focused on maternity care and pregnancy and childbirth. So one of the main issues in this field, and I'm assuming some of you manage pregnant patients, is that there are disparities as well as this reoccurrence in the literature and in media and social media that these patients feel they are not being heard, their families feel that they are not being heard, and good communication and transparent communication in maternity care has been a challenge. That care and that communication and education starts in prenatal care, and shared decision making has been frequently cited as being the gold standard for good patient provider, patient healthcare team communication. And prior to my work, there really was no measure for shared decision making that included both prenatal and intrapartum care. And so I'm going to be discussing why this is important and how you can think about this for your practice. So you can go to the next slide. So we all know that somebody gets pregnant and then they decide that they need to seek out prenatal care, hopefully early in the first trimester. You can go to the next one. And prenatal care, we all know, occurs in the community in ambulatory settings, possibly in federally qualified healthcare settings, possibly in private settings. But for the most part, most healthcare clinics for prenatal care are outside of the hospital. Then as this woman goes along her care trajectory, she may or may not choose to attend childbirth education, but whether it's formal or informal childbirth education, we know that you can go to the next one. We do know that women are receiving education about their pregnancy. They hear stories from their friends and family, and they go on social media and can go on TikTok or YouTube and get all sorts of information. There are also apps. The Baby Center app and What to Expect apps are huge apps that people are the big two apps that people really access. You can go to the next one. Then they go to the hospital when they think they're in labor or they are in labor or they've been scheduled for an admission, whether that's for an induction or a scheduled cesarean birth. Go next. Usually the first person they encounter when they get to the hospital is the nurse, and most nurses in labor and delivery are female and identify as female, so I'm going to use she, her pronouns. And the nurse usually takes their patient's vital signs, does all their admission paperwork. Next is usually their provider, whether it's a midwife or a physician. And I'm going to use she, her again, because most of our providers in labor and delivery do identify as female. And they will conduct a pelvic exam and see, what's going on with labor and if there's labor. And then next, if pain management is intended, then anesthesia is often called. Anesthesia can administer an epidural. And then usually what happens is we have this patient who's now in the bed with continuous fetal monitoring and possibly other interventions. And what we don't know about is next, what the communication is about options and choices about everything that can occur once this patient is admitted to the hospital. So next slide. Now, I just want to couch this communication in that we have a lot of terms out there right now about communication. We hope that all communication is happening in an emotionally safe environment where patients feel comfortable and safe in the environment to talk about what they're feeling and what they're thinking. We hope that that care is trauma informed and that we assume or know that at least minimally 7 out of 10 of our patients have experienced some form of trauma in their life, whether it's with a healthcare provider or not, but that we can't really tell who has experienced trauma or not. And so we do want to use a trauma informed process for communication. And that is also linked directly with respectful maternity care. And AHRQ has done a systematic review of measures in respectful maternity care. And the first iteration of the measure that I'm talking about was actually also published in that. So if you need additional evidence for using choices to measure your decision-making in maternity care, you can reference that as well. And respectful maternity care honors the dignity and personhood, autonomy, and preferences of the person giving birth, of the patient. So we want to make sure that we're respecting autonomy. And autonomy really speaks to having power and power over your body and the power to say no. And so when you think about all of this, and I don't know how many folks in the room actually deliver babies or not, but we often don't give patients a lot of autonomy over when certain interventions can occur or not. And we'll talk about that in a minute. But shared decision-making is a really important part of this process because the healthcare team, the providers, the nurses, everyone on the healthcare team has expertise, clinical expertise that needs to be communicated to patients. And patients have their own expertise about their own bodies, and they have autonomy over their preferences, and they may have received some very good information and education during their prenatal care and during childbirth classes, and perhaps from family and friends. So at the end of the day, there needs to be a conversation about different options and preferences for patients during their labor and birth. And then out of that outcome will lead to person-centered care or patient-centered care, depending on what you want to talk about it, how you want to talk about it. So next slide. So when we think about the perinatal continuum for labor and birth and for prenatal care, labor and birth, most, as I've mentioned, and as you all know, prenatal care occurs in the outpatient setting, and then patients are given all sorts of information in the outpatient setting. Some of it they may or may not remember. Some of it may or may not be documented in their chart, but at some point they're going to get admitted to the hospital for likelihood. I mean, 97 to 98% of births occur in a hospital. And there are different decision points, the decision for admission, what kind of interventions to use or not use. And then at some point, this baby will come out, and that will either be vaginally or via cesarean. And that's another decision point, a possible decision point. So just thinking through all of those different pieces and when and where and how communication happens. Next. So the purpose of this research was to develop a measure for shared decision-making that covered both prenatal and intrapartum care, because previous work in the literature had said we cannot separate the two because there is so much information that patients theoretically have before they come into the hospital, or at least theoretically that they should have. And we really wanted to determine the psychometric properties of this measure. Next. So what I was able to do, thankfully, I was able to receive funding from AHRQ. I was able to work with What to Expect and the Baby Center apps to reach out to their population that they that use their apps to recruit for my survey that included items related to this measure of choices. And the items, there were 22 items in this iteration. So the first iteration of choices has 15 items, and this iteration has 22. There are 16 questions related to labor and birth, and 6 questions related to prenatal care. Go next. The inclusion criteria were they had to have had a live birth in a U.S. hospital. They had to be age 18 or older when they received the survey. They had to be able to take it in English or in Spanish. We did a rigorous translation process into Spanish, and they had to complete all 22 of the questions related of the items for the measure. Exclusion criteria were primarily home birth or birth center birth. Thankfully, we didn't have anybody say they had a stillbirth or a fetal death prior to giving birth. You can go to the next slide. So we completed the survey, and we have an N of 5,820. Just to understand how choices was developed and understand how the items work, is it's considered a unidimensional measure. It has a Cronbach's alpha of 0.7, which is good. And the item mapping indicated that we covered the full scope of the concept of shared decision-making. So there are different pieces of shared decision-making, and I'm happy to have a conversation about that because I think about this all the time. But basically, there are certain tenets of choice talk, preference talk, and decision talk that was set out by Elwin he's out of Dartmouth. And those tenets are in there, as well as certain aspects of autonomy and respect. And that all came out of the iterative process of doing lots of interviewing with women, looking at previous measures for other parts of maternity care, and then putting it all together into one measure. We used rash analysis to determine the psychometric properties. Our infant statistics were all within 0.4 and 1.6. And for outfit statistics, there were 3 items that fell out of range. But for those of you who know all about rash analysis, that's actually less important. And when we discussed it, as a team, we really felt that it was okay to keep those 3 items still into the measure. Next slide. So with these items and with rash analysis, there's what's called endorsement, or questions that people who took the women who took the survey felt were easy to agree with. And this is the areas where people are doing a very good job, hopefully, with communicating and working well with their patients and engaging in shared decision making. So for prenatal care, the easiest question for people to agree with was that they receive the information of when they should go to the hospital. And this was that's great. A lot of times, at least when I was working in labor and delivery, it seemed that people were not necessarily so sure, as well as there's been previous qualitative work that demonstrated that people were not as sure, but this for the survey came out as well. It's easy to agree with. And then for intrapartum care, that they felt heard during their labor, and that the plan for managing their pain was what they had wanted. So most women who had wanted an epidural were able to get an epidural, and that's really good. That speaks to our ability as a system to meet the needs for pain management in this population, which was really important because labor is really painful. Next slide. So the more difficult questions that participants to agree with were that their birth plan was actually written down in their medical record. This has been consistent in both iterations of choices, that this issue of their preferences, what they wanted for their labor and birth for pain management, were not necessarily written into their medical record, which means that that whole big communication piece between outpatient and inpatient is a missed opportunity, or an opportunity now to improve, if that's something that you have with your practice. Oftentimes, especially in certain populations, they'll receive their prenatal care in one clinic, and the providers in that clinic don't actually do births in the hospital where they're planning to give birth. And that is a real challenge. For intrapartum care, the challenges were that there were times during their labor that they felt they received unnecessary treatments. This does speak to some of the overuse that is well documented in obstetrics. And then also this piece, which really came out of the cognitive interviewing that I did. And so I felt really redeemed that this was a harder question, that during their labor, they felt like they just went along with what the midwives and providers told them to do, midwives and physicians told them to do. And this really speaks to a lack of shared decision-making in our field, because we shouldn't be just telling folks the plan of care. They should be actively engaged and should be able to have time to ask questions and think about what they want, and a time to also express their preferences. Next slide. So some of the value and impact of this, Choices 22 has demonstrated reliability and validity. It can be used both in research and QI projects, depending on how you want to use it. If you decide that you want to just have a quality improvement project and not necessarily deal with doing a research project, all the items can be looked at individually or collectively. And right now, Ariadne Labs, if you've heard of Team Birth, they are using this in their projects in hospitals in Texas, as well as the one hospital that they're working with here in Maryland. It can also be used to provide a reference on how communication with primary care and in the ambulatory clinics works with the hospital. And that can provide you with an easy metric to say, hey, we're doing a great job. And, these patients are really recognizing that we're documenting and communicating well with our hospital colleagues, or the opposite. So, and I think that might be it. Yes, please post your questions to the chat. And thank you so much. Hopefully folks are enjoying the talk, and I'm happy to talk offline about choices as well.
Thank you, Dr. Breman, Dr. Nikpour, and Dr. Bridges. We'll go straight into our question and answer period. We only have a few more minutes. Dr. Bridges, I think we have a question in the chat for you. Wonderful project, but I'm unclear about the breadth of the patient community members. Are all in Kansas or Missouri, rural, uninsured?
Thank you. Thank you for that question. For this project, since we are going to design interventions within our family medicine clinic here on the campus, and it's in Wyandotte County in Kansas, and we already know that many of our patients with the worst outcomes are in Wyandotte. We are kind of heavily pulling from that area. We haven't officially limited it to just Kansas or just Wyandotte, but it's kind of naturally happening with the community leaders that we have. But we want to expand this to every clinical department in our university. And so definitely specialty care, and our cancer center has a lot of rural patients that drive in to this area. And so it would be great then to expand it. When we go to those departments, we'll, be thinking about definitely incorporating rural patients. Thank you.
Thank you for that succinct answer. Dr. Nikpour, you probably know my question about the psych admit. So you said that SMI patients basically didn't have any additional admits, but how about those admits to a psychiatric hospital or other systems outside of the system in which you were able to measure?
Yeah, that's a great question. So the UPHS system where Thrive is located does use Epic. And so we have access to things like Care Everywhere if someone gets healthcare outside of the health system at Penn. As for psych hospitals, that's a little bit more challenging. Typically, we'll find out about those kind of through some of our follow-up, or if we have a patient. We've had cases where patients have been discharged from the psych hospital and have actually contacted the team and said, hey, is it possible for me to get some sort of additional support or care here? A lot of our home care managers and community health workers have kind of ongoing relationships with our patients, and we'll check in with them periodically, even after they're discharged. And so we kind of have tabs on, what's going on with them. But it definitely is an area that we really want to expand to. We really want to be able to kind of build systems that are interoperable with psych hospitals, with nursing homes for some of our patients who are not discharged to home and are either discharged to a skilled nursing facility or a rehab facility temporarily, things like that. But as we've kind of been scaling up, that's been one of the things that we're thinking of, is how do we make this really integrated with other healthcare systems? Having Epic really helps, but there's always more opportunities for growth.
Thank you, Jaqueline. Dr. Breman, I have a question for you in the chat. What is the distribution of the providers in choice 22? And then they say family docs versus midwives versus OBGYN. Is there a difference in patient perception?
We haven't looked at that yet, but we did collect the data, so we can certainly take a look at it. Over 75% of the people who took the survey, and we did have a national sample, had physician attending their birth.
Okay, thank you. And I think we maybe a few more quick questions. Dr. Bridges, you spoke of co-development and collaboratively design. What does that mean? How did the patients, the community be part of the design of the dashboard?
Yeah, well, so that part hasn't happened yet. So
Okay, okay, okay.
we're taking this, yeah, the first approach at just stratifying how we think, and then we're going to begin that iterative process and show them this is what we've done. What else would you like to see?
Okay, okay. Dr. Nikpour, if you answer this real quick, we have one more question for Dr. Breman. Um, Payment sustainability for, beyond the project, um, you know, having the services paid for. Have you all looked at that? How could that payments be sustained for the services that you would like to implement to improve the outcomes?
Yeah, so that's one of the things that we've been kind of in conversation with the healthcare system that we're at with the University of Pennsylvania hospital system. They've been really, I think, supportive of kind of implementing Thrive. And as we've sort of seen, this is improving patient outcomes and under some of the value-based payment metrics that our hospitals are under, reducing things like readmissions, ED visits, they're kind of getting some of the cost savings. And so as we go forward thinking about making this sort of its own sustainable program that hospitals can buy into potentially, but also there's a real, I think, investment from our clinician partners and our hospital partners in figuring out how can we keep this kind of alive post grant funding, because it does produce meaningful outcomes that have made an impact on the health system. We're continuing to expand. We're coming into our fourth site shortly as we're sort of building up. And so there's, I think, been a lot of positive momentum, but that's still something we're kind of figuring out as we go.
Thank you. I've just been notified we can go to 3:15 as long as we have questions. So we do have a few more questions. Dr. Breman, I think along the same last question, someone said, I wonder if the gender, race, ethnicity match of clinician-patient matters in patient perception of communication. And that kind of goes to the question that I had. So as you, again, for sustainability, if this is the tool you're providing, others adopt, there's still bias, right? There's provider bias, professional health bias. There's people who have bad bedside manners. They know what to do, but they just don't do it. So do you account for that, how that would impact the program? And going back to that question, the different groups, ethnic and non-ethnic groups, and the perception of communication.
Yes, so this is a patient-reported experience measure. So this is all about what the patient reports experiencing. And so it's their perception only. And we did collect the data. We haven't analyzed it yet because the first step was to establish the psychometric properties, but we did collect data about whether or not the prenatal care provider was the same race or ethnicity as the patient, and whether the provider at birth was as well. We also, because in the hospital, the nurses are actually the ones who interact the most with the patient, we asked specifically about nursing care and whether or not it's they had care from nurses. Most of their nurses the same, some of the nurses the same, or none of the nurses the same ethnicity as them, race and ethnicity. We asked both.
Okay, so that clarifies. So the patient basically provides the feedback. So if it's bad bedside manner, they can let you know, right?
Yeah, and I would say, overwhelmingly from my qualitative work, patients really want to like their providers and they
Yeah.
don't want to say anything bad. And
Yeah.
so it has to be pretty awful for them to say something bad.
For them, right. Thank you. For Thrive, this question is for Thrive. Many studies show worse outcomes for chronic disease if they are associated with mental health disease. Any idea why you did not see similar outcomes in your study?
Yeah, I think that's a great question. And I think the answer is because Thrive seems to work, right? So if you think about, let's say we take two patients, both of them are Medicaid insured, they're low income, they have serious mental illnesses, they've got, similar chronic disease kind of profiles, and they're both hospitalized. One of them goes home, kind of doesn't really have any support, whether that be social, they may not have a follow-up appointment scheduled, and by the time they're able to get, or even a usual source of care outside of the ED, and by the time they're able to even get established with a primary care provider, it may be weeks before they're able to be seen, and there's really no way to kind of close that loop. And again, having sort of those serious mental illnesses as comorbidities can prolong and exacerbate some of those issues. It can cause someone to, not really be able to sort of seek out care on their own and to kind of coordinate their own care. Whereas having a program like Thrive, if someone goes home with a similar kind of chronic disease profile, with a similar mental health kind of diagnosis, if we're able to get someone in the home typically within the first 2 to 4 days after discharge, follow up on any questions that they may have, address some of those needs that were in that pie chart of things like health literacy, transportation, food, if someone maybe is in need of food stamps or whatever it may be. We also are working to help get our patients connected to behavioral health providers, even if, again, that's not what they're being hospitalized for. Better management of their serious mental illnesses can help them stay out of the hospital for their medical conditions. And so I think and again, I will say too, this was a pilot study. And so, we're going to see if these results are kind of replicated in a larger sample in our new site that this RA team has been funding. But I think what we're really seeing is that, and this was true in our qualitative work too, is that patients were really satisfied with the care that they received. So I think the short answer is because Thrive works.
Thank you. So this is the last questions we have right now for you, Dr. Bridges. If the audience, please enter into the chat now if you have additional questions, and then we'll ask you all for your last comments if we don't get any. But Dr. Bridges, the question is, information fatigue, dashboard fatigue is something, especially in the clinics and in among health professionals. How do you, this is a valuable, I think and this is my question, I think this is a valuable tool with the dashboard that you anticipate putting together. How do you get the system to incorporate it? Have you thought about that?
Yes, great question. So we are definitely going to incorporate some qualitative interviews with folks, within our health system to kind of understand what would be the barriers. I am really thinking of this more as a tool, though, for quality improvement teams or people, or groups specifically designing interventions, rather than like a physician would look at this every day, because it would be overwhelming. We certainly plan to make it available at the department level, to share, a sort of overall department, and at the provider level to our family medicine department. That's part of our pilot, just to see how it is utilized, if they want to look at the provider level or at, the department level. But I agree with you. I think it's probably best for QI teams, and, that are going into to use it to design interventions.
Great. Just one comment. If you could put physicians and how they were treating each one of these, that's a good quality metric too, especially for a medical director. I used to be a medical director, so if you could look across physicians and see how they were interacting with the different groups, that would be good feedback. But I think you have a great tool there, and I want to thank all of you for your presentations. But we want to have a last word from each of you, and Dr. Bridges, we can start with you, and Dr. Nikpour and Dr. Breman, and then we'll wrap it up.
Well, thank you so much. I just want to tell you what an honor it is to be part of this. I'm so thankful for AHRQ and the work that that they're funding, and all of this is so important. Thank you.
Yeah, just to kind of echo Dr. Bridges' comments, I want to thank AHRQ and specifically the National Center for Excellence in Primary Care Research for the work that you're doing and that you're funding. I think my experiences with working with Thrive have really shown to me that it does make an impactful difference in patients' lives, and it's been an honor to be a part of it. So I'm happy to share with all of you and happy to connect offline.
Dr. Breman?
Yes, I echo my two colleagues' comments, and if anybody wants to discuss choices and using it for QI or for research, I'm happy to discuss that as well. Thank you to AHRQ, and thank you for Dr. Mack for facilitating today.
It's been my honor. Thank you all, and we want everybody to continue to support AHRQ. Thank you. Matthew, is that it? Are we closing out? Are you closing us out?
Yep, absolutely. Thanks everyone for attending our webinar here today, and really appreciate our presenters, Dr. Mack for facilitating, and all of our attendees for coming today. Thank you very much. And please complete the short evaluation poll after this webinar.
Okay.